So good afternoon to everyone. Thank you for inviting me to do this cryo club. And of course, thanks to all of you who joined us today. I am Ylenia Navarro. I'm a breast radiologist in La Paz Hospital in Madrid. We started doing cryoablation in the breast in 2019. And so far, we have done more than 400 procedures. So today I'm going to try to summarize the possible applications of cryoablation for the breast, which are many, and also I'm going to show you our excellent results. Um, of course, after I hope this is helpful for you, and of course after my presentation, I will be very pleased to answer any question that you may have. So to start with, why do we choose cryoablation for treating the breast among the other thermal ablation techniques? They have similar effectiveness for destroying the tumor, but we choose cryoablation because it is easier to organize in a schedule because there's no need of sedation. We just use the regular local anesthesia as in a normal breast biopsy. Also, we have no indication limits regarding being close to the skin or the pectoral fascia. We can treat big lesions. We can control the process easily with real-time imaging with ultrasound. And also, if it's necessary, if we see an entry area or a relapse, we can do the procedure all over again easily. So the usual technique is that we use ultrasound guide. First, we see the largest axis of the lesion, and according to that, we choose the most suitable needle. After that, we infiltrate the local anesthesia, and we are going to introduce the needle into the center of the lesion, as you can see here, with a security margin of around 1 centimeter. Then we normally do the regular 3-phase protocol, that is 3 phases of 10 minutes each phase, freezing, thawing, and freezing. And again, there is no limits if we are close to the skin or the pectoral fascia. We do not do anything if we are close to the pectoral fascia, is okay. And if we are close to the skin, we have these two very helpful tools. In one hand, we use a hot saline bag covered with a gauze, you can see here, and we put it on the surface of the skin when we see it is turning white, when it's beginning to freeze. And also, if you use Boston system allows you to lower the power of the ice as a percentage, as you can see here. And this is very useful when you're getting close to the skin to protect the skin to freeze. And this is enough. We do not do hydrodissection. Actually, we think it is not necessary for the breast. So we have these two big groups. We can treat malignant lesions with cryoablation, and also we treat benign lesions. First, we are going to start with malignancy because, of course, it is going to be our main group of patients. So, sorry, now. So in malignancy, these are the main clinical scenarios for cryoablation in breast cancer. First, we're going to see patients with breast cancer stages 1 and 2 with no indication of axillary surgery. Then we're going to see stages 3 and 4. Then we're also going to show you how we can treat local metastases in the breast with cryoablation. And lastly, we'll see early breast cancer in selected patients. So let's start with the first group. Patients with breast cancer stages 1 and 2 with no indication of axillary surgery. And here we're referring to elderly patients who are not candidates or refused surgery because of age, and also patients with breast cancer stages 1 and 2, no matter the age, with another primary tumor in a different location in which we are not going to do an axillary surgery in most of the cases. So if you're not that familiar with breast cancer, stages 1 and 2 are tumors below 5 centimeters without or with movable axillary metastases, and also tumors above 5 centimeters, in this case with no axillary metastases. So in breast cancer, we can have two main situations. We can have a tumor that is hormone receptors positive, which are the most frequent, and also triple negatives. When hormone receptors positive, the treatment with hormonal therapy is very important. Actually, in our center, our gynecologists are real experts on this therapy. So in these cases, what we are going to do is treat these patients using a combined treatment consisting of cryoablation together with hormonal therapy. And this is very important. How can we do this? We can do what we call a primary cryoablation, meaning that we do first the cryoablation and then the patient starts with hormonal therapy. Or normally in bigger lesions, we can do first a neoadjuvant hormonal therapy to help decrease in size the lesion, and then we do the cryoablation. And also we can do cryo after failure or resistance to hormonal therapy. And with triple negatives, it's going to be cryoablation and the systemic treatment indicated. So we started doing cryoablation with this group of patients in March 2019. Since then, we have done 160 procedures. Considering a follow-up of at least 1 year, we're talking about 102. And excluding these patients, we have done 96 procedures in 80 patients. About histological types, the most frequent were hormone receptors positive and infiltrating ductal carcinomas. And these are our results. Out of these 80 patients, there was no tumor left after the first cryoablation in 72. That's in 90% of the cases. There was only one patient with a residual tumor, in which we did another cryoablation with no tumor left after that. And we had 7 patients with recurrences. And of course, this is a very interesting group because we need to analyze this group to see what happened in these cases. So if we analyze this group, we see that we have 2 cases with no hormonal treatment because one was a triple negative and the other one was a patient that did not agree with the treatment. 2 patients were non-adherent to hormonal treatment, and 3 cases had a neoadjuvant hormonal treatment failure. So we can think that probably failure or lack of response to hormonal treatment or no systemic treatment increased the probability of recurrence after the cryoablation. And this is why it is so important, this combined treatment that I was talking to you before. It is very important to have cryo and also hormonal therapy to ensure the good results of this management. And we have to always keep this in mind. In these 7 patients, we did a rescue cryoablation in 6 of them, with 4 having no tumor left after that, and we are pending of a new cryo in 2 of these patients. There was only one woman in which we could not do a rescue cryoablation, and she underwent a mastectomy. So overall effectiveness, there was no tumor left after cryoablation in more than 96% of the cases. So this shows this is a very effective, very useful treatment for this group of patients. And we could not control the disease in only 1%. Now let's see some very interesting cases. This was, sorry, I'm trying to move the pictures because I cannot see my presentation now. This was an 80-year-old woman with a 6 millimeters invasive ductal carcinoma in right breast, hormone receptors positive, HER2 negative, and negative axilla. This is a perfect case for cryoablation. Elderly woman, not candidate for surgery, really small lesion, so this is very easy. So this is a good case for a primary cryoablation. We do the ablation and the patient starts with hormonal therapy. This is the procedure, the lesion. We marked it with a marker to not lose it because it was a really small lesion. This is the needle and the ice ball created as always surrounding the tumor completely. And we use the regular protocol. This is 6 months after cryoablation. You can see in mammography, this fat necrosis changes. And the same in ultrasound, fat necrosis area and no vascular flow in Doppler sign. Last control was 3 years and 6 months after cryoablation. Now you can see that there are not even any findings in mammography. We're just seeing the marker, and the same in ultrasound. You can see here the marker. So this is a very good evolution of this patient. This is a different case, an 89-year-old woman with a bigger tumor, 34 millimeters infiltrating ductal carcinoma in left breast. Again, hormone receptors positive, HER2 negative, and negative axilla. This was a bigger tumor, so here we decided, as we have seen before, doing first neoadjuvant hormonal therapy to help decrease in size, and then do the cryo. So this is 6 months after just hormonal therapy. You see the lesion is smaller, measuring 23 millimeters. So this was perfect time to do the cryoablation. That would be a secondary cryoablation. This is the procedure, the lesion, our needle, and as always, the ice ball surrounding perfectly the lesion. 6 months after, we see again fat necrosis area. If you see, it is the same shape and size than the ice ball we created during the procedure, and the same in Doppler sign. There is no vascular flow. The same forward 12 months and 18 months, fibrosis, fat necrosis, no vascular flow. And last control was 2 years after cryoablation. If you compare with diagnosis, now you see this fat necrosis changes, and very important, in contrast mammography, we don't see any enhancement. Later, we are going to see how useful is contrast mammography for these patients, because you have a more objective information and data that there is no tumor left. So this confirms perfectly the good evolution of the patient. And this is one of those cases of a recurrence that I was explaining to you before. She was an 86-year-old woman with a 10 millimeters invasive ductal carcinoma, hormone receptors positive. She was not candidate for surgery, but diagnosis was in 2014 when we hadn't started with cryoablation yet. That's why she was only receiving hormonal therapy. But after 5 years, the tumor became resistant to hormonal treatment, which is very frequent. This was in 2019, so by then we could offer her cryoablation. This is the procedure, our needle, the ice ball. This was it was one of our first patients we did. And the procedure was successful. 2 months after, you can see the cryoablation bed. We confirmed with a biopsy that there were no tumor cells left in the cryoablation area, which we do during the first year that we started with cryoablation. We always did a biopsy of the cryoablation bed to confirm that we have destroyed the tumor. And same evolution 12 months later. But 18 months after, we saw this multicentric relapse with 4 new tumor lesions located far from the cryoablation scar. So this is not a cryo failure. We know this is because the tumor became resistant to hormonal treatment, so we don't have that help from hormonal therapy to stabilize the disease. So we did another procedure to these 4 new lesions in a single time, as you can see here. And after that rescue cryoablation, the patient evolved very well with no relapses until today. Last control was 42 months from the first cryoablation. So after all this experience, this is how we manage nowadays these patients. When hormone receptors positive, if the lesion is below 15 or even 20 millimeters, we can do a primary cryoablation from the start, and the patient begins also with hormonal therapy. If the lesion is bigger, above 20 millimeters, we can start with neoadjuvant hormonal therapy to help decrease in size, and then we do the cryoablation. Follow-up should be every 6 months for 2 years in this group, and after that, if the patient evolves very well, no relapses, we can do yearly controls. If from the start the lesion is bigger than 30 millimeters, we must do a certain follow-up at the beginning after 1 or 2 months, because we need to rule out a possible residual lesion after the cryoablation. And when triple negatives or resistance to hormonal treatment, follow-up must be every 6 months, always, because we need to control those more possible relapses in this group of patients. We do follow up with ultrasound, and if it's possible, we recommend you to use contrast mammography, which is very useful for these patients. We normally do contrast mammography 1 year after the cryoablation. And of course, if we have any doubt of a possible residual lesion or a recurrence, we always do a biopsy. If it is positive, we consider doing a new cryoablation depending on the case. And if it is negative, we continue regular follow-up. Okay, so now let's move to stages 3 and 4. So here we're having a totally different scenario, different patient, different aim, and different expectations. We have a totally different scenario, being a very heterogeneous group of patients according to age, staging, aggressiveness, histology. Many of these cases have aggressive histologies, that meaning more resistance and treatment failure. So it's a group more difficult to manage, to treat. It is a different patient with an advanced disease and usually with an active oncological treatment, that meaning in some cases fragility, comorbidities, or high surgical risk. So, of course, here we have to change our aim. It cannot be the same. In the first group, we saw our aim is to cure breast cancer. But here, with cryoablation, we're going to try to locally control the primary tumor in the breast using cryoablation as an additional treatment tool. So our aim is going to be lower comorbidity and improve the quality of life of this patient, which is a very meaningful goal too. So of course we have to change our expectations. Palliative treatment, it's more like a palliative treatment, not a curative treatment, as I said before. Recurrences, of course, are not going to mean that we fail, we try. And in some cases, we have the possibility of repeat the procedure. It's an easy procedure to do technically, and especially for breast radiologists. And it is almost zero morbidity for the patient, so we can try again. So main indication in this group that need to control the primary tumor in the breast in patients not candidate for surgery with high surgical risk or who refused surgical treatment. In this group of patients with advanced disease, we have treated 16 women. Again, being, as you can see, a very heterogeneous group. About histology, most frequent infiltrating ductal carcinomas, and again, hormone receptors positive. And these are our results. Out of these 16 patients, we could control the disease locally in 10 of them, which is a very good number considering the difficulties of this group. This was one of those patients. She was a 79-year-old woman with a 25 millimeters invasive ductal carcinoma in right breast, already spread to the skin at the moment of diagnosis. You can see the skin is retracted, thickened, and the same in ultrasound. You see the skin is thick. And she had negative axilla, but had a skin metastasis also at the diagnosis. So this was a stage 4. So here we thought that locally we were going to try neoadjuvant hormonal therapy to help this mass decrease in size, and then we will try with cryoablation to locally control. So this is the evolution 9 months after just hormonal therapy. You know that in many cases this breast cancer responds very well to hormonal therapy, and this is the case. You see that the mass is really smaller. You don't see the retraction of the skin, and the lesion now is around 80 millimeters. So there was a perfect time to do the cryoablation and then finishing the local control. So this is the lesion that we have now, the needle, and as always, the ice ball surrounding the lesion completely. 6 months after cryoablation, you see these fat necrosis areas in mammography, and again, very important, no enhancement in contrast mammography. And ultrasound, the same, fat necrosis area, no Doppler sign. And we also had a PET scan 1 year and 6 months after cryoablation. You can see in the CT scan the cryo area with no uptake in PET. So this confirms that we achieved local control for this patient. Okay, now let's see how we can treat also local metastasis in the breast with cryoablation. We have treated axillary nodes, metastatic axillary nodes, also skin metastasis, and chest wall metastasis. About numbers, we have treated 3 patients with axillary metastasis, in total 5 nodes, 8 patients with skin metastasis, in total 27 lesions, and 2 patients with chest wall metastasis, in total 2 lesions. So I'm going to show you one of those patients in which we treated the axilla. She was an 87-year-old woman with a 32 millimeters invasive ductal carcinoma. It was a grade 3, triple negative, and with a Ki-67 of an 80%, so very aggressive tumor. She already had 1 lymph node positive in the axilla. She was a fragile patient, not candidate for surgery. So with this situation, we decided first to do the cryoablation of the primary tumor in the breast. So this was a 32 millimeters lesion. We choose an ice-4 needle, which is the needle that makes the biggest ice ball, and regular protocol to ensure that we are treating correctly the lesion. This is a staging study. It was a PET-CT 2 months after cryoablation. You see the cryo area, still with a little uptake. This is normal because it's an early study. And also you can see the lymph node positive in the axilla. So here the situation is that we have an elderly patient, very fragile, with a very aggressive tumor, in which we probably are going to achieve local control in the breast. So we decided to treat also the lymph node in the axilla with cryoablation to try to stop or at least slower the spread of the disease. So this is how we treat the lymph node. You see here the node in the axilla, and the procedure is the same as with a lesion in the breast. We go through the node with our needle, and we do the same ice ball surrounding totally the lymph node. And this is normally the position, like we put the patient in a slightly lateral position, as always, as comfortable as possible for her and also for us. And this is the evolution 10 months after. We see locally in the breast, fat necrosis area, no vascular flow, and very important, no uptake in PET scan. And the same with the axilla. We see in ultrasound this hyperechoic area peripheral to the node, which is normal after cryoablation, and no pathological uptake in PET scan. And we also didn't see any new lymph nodes positive. So here we achieve local control in the breast and also in the axilla. Okay, and about the skin, this was one of the patients that we treated. She was a 62-year-old woman with a lobular carcinoma in right breast. She underwent a bilateral mastectomy that could not complete the treatment. That's why she's been having local recurrences since 2015. In 2021, we saw a new local dermal progression. We saw these new dermal lesions in right breast. This is one and this is the other. We confirmed with the biopsy that they were metastases from the lobular carcinoma. So this patient already had multiple surgeries because of the multiple recurrences, some of them very aggressive surgeries. So by this time, we decided to try to treat these lesions with cryoablation to avoid her another surgery. So this is the procedure. And well, first with this, I wanted to explain to you several things. First, Of course, this is not the first case you're going to do if you start doing breast cryoablation, but this is to show you how versatile this technique is. You can do multiple things in the breast with cryoablation with no problem at all. With experience, you learn how to manage these situations very easily. And the key is to lose fear of, especially with the skin, that you can see with this that we can protect the skin very easily and with no complications after the procedure. Second, when we treat the skin, what we do is what we see here. First, we localize the lesion with the ultrasound. And with that, we mark the extension of the lesion with a marker, as you can see here. This is one of the lesions, and this is the other. And then we do the procedure with not using the ultrasound probe, just controlling directly with our eyes what is happening in the skin. And this is much easier to control the procedure doing that than with the ultrasound. Okay, and third, we are treating the skin. So we are going to use the needle that makes the smallest ice ball. That is ice needle from Boston. And also we are treating the skin. So we are going to use that tool that I was explaining to you before, that we can lower the power of the ice. So here we can do with 30%, maybe with 50% if the patient tolerates it well and we can handle it. And also we are going to shorten its pace. We're not going to do 10, 10, 10. That would be too aggressive for this. With 5 minutes, it's okay. So this is a video so you can see better how we manage this. I hope you can hear me well. So here you see that this area, this white area, we are pressing directly the skin. And you don't have to be afraid of this because you want this to happen, because you want to destroy the lesion that is located into the skin. So the key is to hold on for a little bit, that pressing. And then we put our hot saline back. And you're going to see how fast and how easily the skin recovers its normal color again. You see, almost normal color again. So the key is to find this balance between freezing and helping the skin to recover. And believe me that at some point with some experience, you learn how to do this very easily. You see? Okay, so we did this, moving the needle. So area by area, where we completed the whole lesion, and the same with the other one. And this is the evolution 1 year after. We don't see any lesions in ultrasound, and the evolution of the skin clinically is very good too. We're just seeing a scar. And the patient and the other patient that we have treated skin lesion have never had any complications, not the day after cryoablation or the days after. Okay, now, lastly, we're going to see early breast cancer in selected patients. So as you know, thanks to screening programs and better equipment, now we can detect really small breast cancers. In those cases, conservative surgery is indicated, but nowadays, percutaneous techniques such as cryoablation are beginning to be considered as an alternative. Now let's take the evidence to date. In 2004, Seville et al. Published a study in which they treated with cryoablation 27 invasive ductal carcinomas less than 10 millimeters in size. After they did surgery, with a 100% success rate, meaning no infiltrating tumor left in the surgical specimen. In 2015, there was a study by Poplak et al., and 1 year later, another one by the ECOSOC. As conclusions of these trials, it seems to be that cryoablation is a little less effective in lesions between 10 and 20 millimeters, and especially when there is an intraductal component associated. And later we are going to understand why this happens. In 2014, started the ICE3, which is a very important trial with recently published results. They have treated lesions below 50 millimeters with no surgery after cryoablation. With a follow-up of 5 years, they have achieved a no recurrence rate of 96%. So considering this data and having such great results with the first group of elderly patients, we decided to start a similar study in our hospital too. It is a trial led by our colleague, Dr. Ylenia Navarro, and we have also published a paper with preliminary results in the Breast Cancer Research and Treatment Journal. This is it, and I invite all of you to check it out. So what we are doing is that we are treating low-risk breast cancer in selected patients with cryoablation. Then these patients go to surgery, and our aim is to prove that there is no infiltrating tumor left in the surgical specimen. These are our inclusion criteria. The lesion must be less than 20 millimeters, hormone receptors positive, HER2 negative, and negative axilla. Candidates for conservative surgery, and we do not include extensive intraductal component, which we see with MRI. Why? Because we know in those cases, the real margins and size of the lesion are less clear, so it could lead to failure of the cryoablation. We started this study in April 2021, and we have finished it in April of 2024 with 92 patients. Here we present the results until April 2023. By then, we have treated 52 invasive ductal carcinomas, with 32 being pure, meaning no intraductal component associated, and 20 being mixed with intraductal component associated. In all the cases, we did the triple phase protocol that we explained before. And these are the results. After the cryoablation, there was no infiltrating tumor left in the surgical specimens in the group of pure carcinomas, in all the cases of pure carcinomas. And there were 4 cases with infiltrating tumor left in the group of mixed carcinomas. Overall effectiveness was 92%, and all specimens had tumor-free margins. So what happened in those cases? Again, as we have said before, intraductal component make the real size of the lesion less clear. So probably these tumors were bigger than we thought. That's why we recommend you, if you have a lesion with intraductal component, we recommend you to use a needle that broadly covers the whole size of the tumor, estimated by ultrasound together with MRI if possible. If you use a Boston system, we recommend to use iceberg needle above 12 millimeters of the lesion. So in this group of malignant lesions, we have seen that cryoablation allows morbidity-free management of breast carcinoma in early stages when no indication of axillary surgery, and together with hormonal therapy as a combined treatment. In hormone receptors negative and resistance to hormonal treatment, we must do a close and continuous follow-up to assess possible relapses. Cryoablation can also be useful in advanced stages, as we have seen, considering, of course, higher failure rates because of the difficulties of this group. And it may also be a safe alternative to conservative surgery in low-risk breast cancer in selected patients. So now let's see some cases of benign lesions. We are treating with cryoablation these entities. You know that papillomas are the indication approved by the FDA in the USA. But today I wanted to show you some more interesting cases. We have treated some cases of papillomas located inside the nipple. And also we are treating skin fistulas in chronic mastitis. We are very satisfied with this. And I think we are having very good results, and this is very important for the patients. And I will explain this later. So about papillomas. Here are some cases of papillomas located inside the nipple. This was a 72-year-old woman with a right breast telorea. We saw this papilloma confirmed with a biopsy. We saw it perfectly in the MRI and also in ultrasound. And because of the location, we offered the patient to try to treat it with cryoablation. This is the procedure. Again, we are treating the skin, the nipple area. So we are going to use an IC needle, the needle that makes the smallest ice ball. Again, we are doing shorter phases. 6 minutes phase is okay. It was okay in this case. And we are lowering the power between 50-30%. We always adapt this to its case. We don't have a strict protocol for this. So this is the procedure. I left the sound on, although it's in Spanish, but you can see that the patient is relaxed. She's not screaming. She's not feeling any pain. This is our needle. The papilloma is here in the area of the nipple, and we are going through it with the needle. You can hear that the patient's not saying anything, so she's really fine. Here's the tip of the needle. As I said before, like 1 centimeter of security margin is okay. And now we are going to start the procedure. So now we are going to see this shadow of the ice ball beginning to form. And now we're asking the patient if she's okay.
No, noto nada.
She's saying that she doesn't feel anything and that she's fabulous. Actually, now she's going to ask if she can go to the hairdresser later because she has an appointment, so she's really doing fine. Now she's asking back. Okay, so moving a little forward in the same procedure, you see the ice ball is bigger, very close to the skin, and everything is okay. This is the same patient, so you can see better in the pictures the evolution during the process. So here we have the cryo needle. This is the white area that we are freezing directly the nipple, but we want this because the papilloma is located here, so we want to destroy it. So as we have seen before with the skin lesions, we have to hold on this for a little bit. Then we use the hot saline back, and after a while, the nipple recovers its normal color again. You see, almost like before the procedure. This is a different patient, but also with the papilloma located inside the nipple, so you can see it better how we do this. So the nipple is white, as you can see. We are freezing it. We hold on for a little bit, and then we put the hot saline back. And you're going to see again how easily the nipple recovers its normal color again. Also, the patient does not feel any pain. She's really doing fine. You see, almost normal color again. And no complications in none of these patients the afternoon after the cryoablation or the days before. Okay, and lastly, I'm going to talk to you about skin fistulas in chronic mastitis. This is a big problem for the patient because there is no solution for this. Surgery is not effective, and in some centers, they treat them with alcohol. And actually, we have tried that with alcohol, but not with very good results. So after a lot of experience with these other cases, one day we had one of these patients with a skin fistula, skin chronic fistula, and we decided to try to treat it with cryoablation, using the ice to try to induce a fibrosis along the tract of the fistula and try to close it. And this is actually the first patient we did. She was a 49-year-old woman with 2 years of recurrent mastitis. You can see here the episodes of acute mastitis. And she had a skin fistula in the last year. This is the fistula in the ultrasound. So this is the procedure. Again, we use IC needle because we are treating the skin. We suture its phase. 4 or 5 minutes is okay. And with 50% of the power is enough too. What we do is we place the needle along the long tract of the fistula like this, and we do the ice ball there. This is during the procedure. You see the cryo needle, and here you see that we are directly freezing the hole in the skin. The hole in the skin is is here, and we want this because we want to close it. And this is the evolution right after finishing the procedure. So you can see the skin is perfectly fine. And this is the evolution. 1 month after, we can see this hyperechoic area around the tract of the fistula with no imaging findings after that. Last control is almost 3 years now with no imaging findings. But the most important thing during following up of this patient is not the imaging, because sometimes there are not big changes, but the most important part is the clinical, is the symptoms, is the secretion, is the clinical evolution. So here you can see 3 months after, just 3 months after cryoablation, if you compare with those episodes of vacuum mastitis, look how great the breast looks now, with almost the whole healed. And here, 2 years after, with the whole fistula closed and looking this good. So you can imagine how grateful this patient is after 2 years having this nonstop. So the quality of life of this patient was excellent now. And this seems to be a not so frequent entity, but when you start treating these patients, you begin to receive more and more cases. And in some cases, we have patients not with 2 years, but with 10 or even 20, 30 years with secretion. So if you can help these women like this, I mean, this is very exciting for us. We started doing this in April 2022 with that first patient. And so far we have treated 21 patients. Again, it is not that infrequent. With a follow-up of at least 6 months, we have 80 patients with 14 patients with an excellent clinical evolution, meaning no secretion at all. So in this group of benign lesions, you know that we can treat fibroadenomas. And we can also apply it in other benign lesions, depending on the case, of course, in selected patients. And we are having promising results in the treatment of skin fistulas in chronic mastitis. Thank you very much. Well, so I tried to summarize the applications of cryoablation. Again, you can see we can do many things. I think it is really satisfying for us to be able to do so many things on the breast with a very easy technique technically and with no morbidity at all.